companies could not sell them as glucose-lowering medication. Now when we know that the effects on cardiovascular disease and kidneys even stronger on lower levels, this is not anything that it should be as soon as possible. We should get rid of these cutoffs. So I would combine with an SGLT2 inhibitor, but there are also other options. I mean, Mark, do you want to continue?
Not really. I think you've really covered it very well.
Yeah. Okay. I think we got that too. Thank you. So the other question is quite simple. How often do we request for HbA1c, Professor Cooper?
I think it depends on the situation. I think clinically in a regularly monitored patient, you at least want to measure it several times a year, and particularly if you're changing treatment, you need to see if the treatment's working, or if you've over-treated the patient, or if you can, it's part of your management decision plan.
Yeah.
And I answer very pragmatically what I do, and I always try to teach our students, our internists here in Finland. Treatment for instance, diabetic kidney disease, the standard of care is 5 fingers, 5-finger rule. First is optimal glycemic control, A1C below 7. Optimal blood pressure control below 140/90, but if you have 1 gram proteinuria below 130/80. Start an ARB or an ACE inhibitor. 4, stop smoking. 5, consider statin. Now, when I see these patients, and I ask my students also, when you see patients, if you don't see an A1C result which is on the target, you need to take action. So this is the reason why, yes, as Mark Cooper was saying, of course we need to monitor A1C. And if you're not happy with the A1C level, you need to test it next time, and you need to take action if you haven't achieved the result. So what I always, when I dictate or when I write in the medical files, I write whether the patient has achieved the target. If not, I need to take action. If the patient has not achieved the target of the blood pressure, I need to take action. So it's very pragmatic view. So the answer is yes, you have to, as Mark Cooper was saying, it depends, but I would say you have to do it every time to see that you have reached the target.
Yep. And sometimes we want to know if our patients are staying on their target. Right?
And that is also true. Absolutely.
Yeah. Okay. So usually it's around like every 3 months, I guess, for most of us. Yeah. Okay. So the next question is, can linagliptin be given as monotherapy to all CKD patients looking at the safety it's offering? Yeah.
It's, it's as a matter of fact, I know this because when I see a lot of these patients just before they start analysis, there are not many options we can use. You cannot use metformin, you cannot use sulfonylurea, you can use insulin, but then, it's a risk of hypoglycemia is quite high. Then you can, thiazolidinediones, basically you could use, but then you have the fluid retention. So it's actually the only option you have. And then it's linagliptin.
Yeah. Professor Cooper, any words to add?
No, I just think in that fact it's an ideal drug in that setting.
In fact, I was once asked in an interview how linagliptin has changed my practice, and the answer I gave was that it has made life easier for me because patients with renal disease, I don't have a hard time now trying to convince them to go on insulin because I have a better choice that's easier to use.
Absolutely.
Okay, so we have the next question. Can linagliptin be given in a mild hypertensive with pre-DM, similar to the first question, with mild microalb at 2.5 as monotherapy? Oh, okay. So I think we have to answer, can we give it as just 2.5 milligrams? Or do we have...
I don't know why you would. There's not much evidence that would make a difference. You don't need to alter the dose. This is a one dose in all situations, so I wouldn't be trying to give 2.5. This might be relevant to other DPP-4 inhibitors, but definitely with Tradjenta, you just give one dose. Don't need to make it complicated.
I understand the question of the microalbuminuria because you might reduce that, but again, there's no data and pre-diabetes is not studied. So I think that's a little bit of a far-fetched conclusion, but I understand the thinking about it, and maybe in the future, who knows?
Yeah.
But it needs to be studied.
Yeah, and this question actually follows that. By which mechanism does linagliptin reduce albuminuria?
I think that's a good question. I mean, first of all, it reduces glucose. If you reduce glucose, you'll reduce albuminuria. But more importantly, it's not really known. So it's all based on experimental work. And there is some evidence that there's a lot of DPP-4 in the renal tubule, and maybe it's an action there. There's some other interesting other pathways. It can act as an antioxidant. But to be honest, we don't really have an exact explanation for how the drug works.
That's true. That's true. But as Marco was saying, we don't know. But experimental work has shown antifibrotic effects. And one reason why we studied in the first place in the Marlina was that we thought there might be antifibrotic effects. It's also interesting if you think about, you compare it with SGLT2 inhibitors and GLP-1 agonists. All three, also DPP-4 inhibitors, are to some extent natriuretic, but the effect is not on the proximal tubule, it's on the distal tubule. So you go beyond the macula densa. So you don't have these hard effects that you see on the kidneys with SGLT2 inhibitors. And the reason why you don't see them with the GLP-1 agonists is that they have another effect than just the generation of adenosine from the macula densa, which is constricting the afferent arteriole. You actually have vasodilation of the afferent arteriole. So although it's natriuretic, sodium-rich macula densa, you don't have the effects on the hard kidney endpoint with GLP-1 agonists. But we don't know. But I would say that having the data from the Carmelina, you reduce albuminuria. An increase in albuminuria is associated with increased risk of cardiovascular disease, increased risk of progression of kidney disease. Although we haven't seen effect on the heart kidney endpoint yet, maybe by time, but that question will probably not be answered. But I think it goes in the right direction, and that's good news at least.
Yeah, I think I agree with that. The direction is in the right way. Okay. This question pertains to, in clinical practice, some rate of GI disorder with the Tradjenta Duo combination. Do we have data to compare Tradjenta Duo versus the other fixed dose combinations, DPP-4 and metformin, in regards to this AE? Thank you. So, yeah.
I don't have the answer to that. Maybe Mark, can you answer? I don't know, because it's difficult to tell. It's because of reporting and you know, it's difficult to compare different, you know, because this is or doctors that report side effects, and then it also has to do with, you know, which drugs are more often used and so on. But I'm not aware of that it would be more. What I can say that metformin is actually causing most of these GI problems. I don't think it comes from linagliptin.
Yeah, I think in clinical practice, I think it's patient specific. Some patients would really have some complaints like this, but it's not specific to the combination, because you can also have it with other combinations.
Sure.
So the next question is, can we give linagliptin in post-KT patients who develop diabetes? So new onset diabetes from transplant?
Yes.
Easy answer, yes. Easy answer, yes, as I showed in one of my slides. Sorry, Mark.
Yeah.
No, you can, absolutely.
Yeah. So that was fast. It's yes, agree. Okay. The next question is how to choose when to use the GLP-1 RAs or DPP-4 inhibitors. Is it possible to combine both classes?
Well, I'll answer. First of all, there's no role to combine them, because there's no evidence that when they've even tested it, not that you would logically do it, there's no evidence that they work together. So one combination that's completely irrelevant. In terms of when you would use a GLP-1 receptor agonist compared to a DPP-4 inhibitor, there's no question that the injectables, first of all, they're injectable. A lot of patients don't want to inject, they prefer a tablet. So we tend in the earlier course of diabetes to generally consider oral agents rather than injectable. But there are some particular advantages which you need to consider the very obese patient. If you have established vascular disease or renal disease, if you're not going to use an SGLT2 inhibitor in that context, you might use a GLP-1 receptor agonist. And we must concede that they are probably more potent at glucose lowering than most of the oral agents. So when you want to get more effective glucose lowering quicker, this would be worth considering.
Yeah. Okay. So I think the next question is, I don't know how to simplify this. Do we have evidence on barren women with the use of DPP-4 inhibitor?
On what women, sorry?
Barren.
What is
that? What they're asking.
Infertile.
Yeah, but what about it? It doesn't restore fertility.
Yeah.
No.
Okay, and I don't think no specific studies on that, right? Okay. Next question is, so even though linagliptin causes less hypoglycemia compared to the SU, and yet the mortality is about the same, doesn't this contradict earlier studies that show hypoglycemia attacks relate to higher CV death?
I think it's a very good question, and it is possible. My own feeling is that these were very early patients in the diabetes history, so there's already a low mortality already with a low event rate. When you have low mortality and low event rates, you often cannot detect differences. Probably on reflection, it might have been better for them to have done a study like Carolina in a Carmelina population, where you have more patients. You need to have people having ischemic heart disease, so when they have a hypoglycemic episode, something happens to them. Whereas if you have early type 2 diabetes, where people don't have widespread vascular disease, they can hypo, but it won't have a deleterious impact on their heart because their heart's functioning pretty well. So we don't really know. So it's only theoretical, but one would expect that this study be done later in a more advanced patient. We might have seen a result like we saw, let's say, in ACCORD, where there was increased hypoglycemia and there was increased death, but they were not even then able to link the hypoglycemia to death directly. So it's a very difficult question to answer.
Yeah.
We need to, when we look at all these data, as Mark was saying, these data from the ACCORD, they were to some extent interpret that you should not reduce A1C because it's dangerous. So that was a misinterpretation of the data. Of course, it's important to reduce the A1C, but that was a very, very sick patient group with a lot of background medications. And now we have another study where we of course try to see if sulfonylureas that have been shown in many meta-analyses and pooled analyses that it might cause cardiovascular disease, and then we didn't see. But as Mark is saying, these were not very sick patients, so we might have had to go on for another 5-10 years to have seen the effect. So I think we need to, the interpretation we can do is that SUs are safe in terms of cardiovascular risk in early diabetes. But when the years goes on, the risk might be there, and especially what we already saw, that there was less hypoglycemia. So I think we should not let's say, simplify the conclusion and say that sulfonylureas are safe. I'm not so sure about that in the long run.
Yeah. And I think that's related to another question I see on the box. Would you still use SU even with Carolina data regarding the hypos? And do you believe there's higher CV risk from the meta-analysis with SU? So it's...
I do. I think so. But again, the data on the use of SUs is so problematic because you have so many meta-analyses that show it's safe, some show it causes, but keep in mind that meta-analysis are only hypothesis-generating studies. Carolina was a cardiovascular trial that actually addressed it, and what it showed early those with risk factors but not established and very sick patients, it seemed not to cause. But as Mark was pointing out, we don't know what would have happened in a Carmelina-like study. I think that would have been a very similar result as in the ACCORD.
Yeah. Okay.
But that's my personal view. Yeah. We don't know. We don't know.
Yeah. Professor Cooper, no further addition?
I agree with Henrik.
Okay. So the other question is, can Tradjenta be used for type 2 diabetics with chronic Hep B, hepatitis on antiviral treatment?
Yes. It's safe.
Yeah. Okay. Can you explain why some patients experience loss of appetite on DPP-4 inhibitors? Is there a difference among the DPP-4 inhibitors regarding this side effect?
So this is an interesting question because I have seen patients with very unusual symptoms on DPP-4 inhibitors. They're exceptionally rare and they're very safe drugs, but there is no question there are patients that can develop very unusual side effects on these drugs. Sometimes it's class related, and sometimes you just change them to another DPP-4 inhibitor and that doesn't occur. So I think it's unexplained, but there's no question there are people that develop unusual symptoms on DPP-4 inhibitors. And I believe they're real, but rare.
Yeah. Professor Group?
No, I agree.
I agree too. There are sometimes some side effects we can't really explain or adverse events, but it's rare. Agree. So how do we treat a 67-year-old female on dialysis? Oh, this is related to COVID. Tested to be passive on rapid antigen for COVID-19 with colds and mild cough, but chest X-ray has no pneumonia. Do we give antibiotic, prednisone, and cefuroxime? Oh, so this is a question on, well, for a renal patient with COVID, I guess.
I don't think I can answer that question. Yes. I've been lucky in Australia, we've had very little COVID, though we're getting some, but it's much lower than in other parts of the world. I don't think Finland's been particularly bad. I think you need to ask an English or an American doctor.
Right. I think the question might have to do, I think it was in Diabetes Care, an editorial on DPP-4s and COVID. It's better I don't answer because I don't recall exactly what was in the but it was Michael Nauk. So watch out for and Joris Meyer. Those two guys, the German guys, they wrote a review or editorial about DPP-4s and COVID. So it's better that we refer to that than we answer.
I think I saw that article as well. Yeah, so something to do with that. I read that, but go back to the article then. Okay. Can we use Gentadueto 2.5 over 1,000 twice a day? Should we not use linagliptin once daily?
So that's really nothing to do with the linagliptin, that's to do with the metformin. Yeah. Because the metformin you're not using a long-acting metformin, it's a shorter-acting. You need to give metformin twice a day, and because the linagliptin dose is 5 milligrams a day and you've got 2 tablets, you have to give them 2.5 in the morning and afternoon. It's nothing to do with the linagliptin, it's to do with the metformin.
It's just easier to give it twice because we have to give the metformin twice a day at that
dose. Yes, you may as well just put that's all. It's just practical. But if you had a metformin XR preparation, which I think saxagliptin has, then you could do it differently. But I don't think it's a big issue.
Yeah, we don't have it with linagliptin. Okay. Is there a difference between in the kidney outcomes between the DPP-4 inhibitors and the GLP-1 RAs?
Well, no one's done a direct comparison, but you get the impression that the GLP-1 agonists definitely have a bigger reduction in albuminuria, and some of the more recent studies are starting to see effects on GFR, which we've not seen with the DPP-4 inhibitors. So I think they're probably more renoprotective. The real question is not that. The real question is how good are GLP receptor agonists on the kidney compared to an SGLT2 inhibitor? And this is where I think that is an important question, which has not been answered.
I would add to that for GLP-1 agonists, all studies have shown that they reduce albuminuria. But for DPP-4s, it's actually only linagliptin. The other ones, we don't know. Probably
modest, yeah.
Exactly.
Yeah. Okay, so it's not as effect.
Well,
no, not for DPP-4, but for GLP-1 agonists, I would say it is.
Yeah.
So I think the next question is again for COVID about the treatment drugs. So we're not answering this, right? We talked about.
We are not the experts on that.
I'm not.
Yeah. Lifestyles such as exercise have effect on diabetes?
Of course.
Yes.
You could answer that, I think.
Yeah.
You could answer that.
I can answer that, yes. Actually, the lack of intensive physical activity is a risk factor for dying early, cardiovascular disease, and also kidney disease. So active physical activity means basically that you need to sweat a little bit. So physical activity is good for you. Yeah. We have published a lot on physical activity and diabetes and diabetic complications.
Yeah, there's a lot of benefits we can get from physical activity.
Yeah.
Okay. This question is for Beringer. Will there be a linagliptin metformin XR combination for better adherence? We can't answer that.
No clue. No idea.
Yeah, I think we've gone through all the questions, and Sam has said, so there's another question that just came in. Which one would be a better regimen? EMPA, Lina plus metformin, or Lina, metformin? I think it's the same. I don't know if you can see the question.
I think what they're asking really is if you've got the combination, should it be if you're taking EMPA, Lina and metformin, would you do the EMPA and Lina in one tablet or the Lina and the metformin in one tablet? Personally, I don't know what it's like with the cost structure in Philippines, but in Australia, because EMPA and Lina are more expensive than metformin, it's much cleverer to buy the EMPA Lina as one tablet and then just buy the metformin, which is very cheap. But they're all going to work the same way. The efficacy will be similar.
Yep, effect-wise the same, but it will be the cost that might be lower.
So the cost is by the EMPA Lina, maybe.
Yeah. Agree. Same here. And then, which beta blocker would be better to give to CKD4 on linagliptin?
CKD5.
CKD5,
I don't think it matters, really.
I agree with Mark. It basically we are using the selective beta blockers that we are using. But I agree. I don't think it matters.
Yeah, I think we have exhausted all the questions. But
there is one. There's one from Lam Pam. I think asked for as a raised hand.
Oh. There's one.
No, I think that might be.
Okay.
I don't staff. And a raised hand. Yeah. But there are
staff. I think that's staff.
Okay.
There is a comment on the chat box. I think I saw it somewhere. They want to see you with your hat on, Professor Group.
Yeah. Put your hat on.
Yeah, I will.
Well, okay.
This is the tail-coated doctoral hat in Finland, and so we had a wonderful wonderful event, 3 hours of grilling the candidate, but he did very well. So he was on diabetic kidney disease, as you can imagine.
Wow.
All right.
You look very nice, really, prim and
Thank
proper.
But also the 10 years, we're celebrating the 10 years. I thought it's also proper to wear this outfit and maybe not go and change.
Okay, so he says here to Professor Group, very handsome.
Thank you.
I have another admirer. Okay, I think we are right on time. So before we close, can I ask each of you to just give a few words of closing before I close the session?
Okay, so
Professor,
I'd like to say that I think we've had a very extensive discussion about linagliptin, 10 years of linagliptin. I think it's one of the easiest drugs to use in diabetes. It reminds me a bit of the angiotensin II receptor antagonists in hypertension, which turned out to be very easy for hypertension. And we've had very easy drugs for lipid lowering. And now we are lucky that in diabetes, finally, we've got a class of drugs that are very easy to use with a remarkable side effect profile. And they've been so extensively studied, and linagliptin in particular has beautiful safety data for cardiovascular and renal disease in both early and long-term diabetic patients, and also that the program is unbelievably extensive in how much they've studied this drug, really, which is much more than what we know about metformin or sulfonylurea. So I might stop there.
yeah.
Yes, I can. I think, again, as I was saying, that it's very important to first actually look for the problems. For instance, presence of kidney disease, presence of cardiovascular disease, presence of heart failure, because that is important. The guidelines say that we should do that. But before that's maybe then, that will drive the choice of medication very carefully. However, it starts much earlier. And remember what I said, the 5-finger rule, that is at any stage of diabetes. Go for the targets, make sure that you take action. And if you have not achieved the targets, you have to take action. And it's a good way to look at what we have learned today and during the past years in terms of managing the treatment of type 2 diabetes. We have learned a lot, and we have a totally different situation. We have actually very efficacious drugs that do not have have side effects that jeopardize the results. So screen for complications. Think about how these medications work and their efficacy and safety, and then take action.
Thank you very much for those closing remarks. Tonight we have had an extensive discussion, talk about an outstanding molecule, I think, a glucose-lowering drug that is effective for a broad range of type 2 diabetic patients with with 2 volts actually to support its safety. So, and we are celebrating the 10 years of linagliptin, as mentioned by Professor Group. So we're glad we have something like this. And I think I'd like to borrow a line from, was it Professor Merlin Thomas, who said that this is like something we can fire and forget? Similar to the statins, you give it and then you don't forget about it because it is such a safe medication to use. I think it was from him, I heard. I'm not sure. Anyway, so I'd like to say thank you, Professor Cooper, Professor Group. It was great discussing with the two of you and hearing about linagliptin. And to the attendees, thank you for joining us as we celebrate the 10 years of linagliptin, a wonderful medication. Thank you, and good evening, everyone.
All the best. Bye-bye.
You too. Keep safe.
You too.
Good night, everyone.